Hello everyone. Welcome back to Clinical Problem Solvers. Today we are back with Tuesday VMR with all of you, and we are very excited to host this session. And I am very lucky and honored to again co-discuss with the our very own Dr. Ravi. And just handing the mic to Dr. Ravi to say some words. And thank you for the opportunity.
Oh, no, thank you for stepping up to co-discuss. I'm very excited. Thank you. It's always a pleasure. I'm very appreciative of everything that Anmol does for CPS, all the wonderful cases. You brought a very unique case last Friday, so I'm still feeling very, what do you call it? I'm still learning a lot from that case as it's percolating in my mind. And all the wonderful contributions that you do with teaching points and scribing and everything, all the support that you give us. And before we get underway, can ask Sam, who is helping us for scribing today. How are you doing, Sam?
I'm doing great. It's awesome to be here. I'm coming to you from Maine where it is freezing cold. But we're keeping warm with all of the knowledge, so I'm very excited to be here.
Excellent. And I'm always looking out for Sam's cat, who makes a guest appearance every now and then. And then also Lyra, who's going to be helping us once again with teaching points. How are you, Lyra? Everything good?
Hi everyone. Yeah, it's been a beautiful day. It's finally snowing here. It's been raining yesterday, but it's finally snowing here. So very excited to learn from you today.
Awesome. Well, I don't mind it snowing, except if it interferes with my travel plans. So, but always looking forward to the snow. All right, and we should deploy the whiteboard and Aaron, if you want to start with the first aliquot, and Anmol, you can take first stab at the first aliquot.
All right. So this patient is a 20-year-old female who is coming in for a rash.
That is an interesting start. I love derma cases too because why I love that because I am not very good at that. So that makes it even more interesting for me to understand and learn more. I think the age was 28 or 20.
20.
20. Okay. So I think, first of all, if the patient is saying that she has a rash, I would want to know what the location of the rash is. And since what time the rash is present. Was it gradual in onset or was it sudden in onset? So these will be the first two important questions. And then we can actually analyze the rash based on the depth and the spread. How vast is it spread all over the body? Is it present in many places or is it just localized? And what is the depth of the rash? So that also gives some important clues. And in which setting did the patient present? Was it an emergency setting or an outpatient setting? Also makes me think about how severe this presentation would be. And I think the no miss causes or the dangerous causes with the patient presenting with rash would be things like TEN or SJS, but we are very far from going in that direction. But then for that category, we would want to know the vitals of the patient and any history of fever. I think we have to look for some alarm symptoms so that we can go towards that category. So with just one chief complaint of a rash, I think there are some important questions which needs to be answered before we can go further. And if we know the time duration of the rash and if it was sudden, then I would want to know if there was any recent exposure for the patient. Yeah, so I think these are some of my basic questions as of now with this chief complaint. What do you think, Dr. Ravi?
Well, Anmol, absolutely wonderful start. I am so impressed with just what you had to say for the initial aliquot, like laying out the groundwork as to the approach to a rash. Yeah, rash is very difficult. Like the approach to rash can vary. Many dermatologists may have one unique method of trying to decipher the breakdown of a rash. Internists may have another way how a rash may evolve. I kind of think about it as two systems. Before even trying to describe the rash, when did it start? Like you mentioned, the time course. is there anything around the time that the rash occurred? Because if you don't know, a lot of things, a lot of outside things, so things external to the skin can initiate a rash or instigate a rash. Things like any products, right? Every day we use products that may enhance skincare, could potentially cause a reaction. Medications could do it too. You take medications internally, and that could also erupt into a rash, like antibiotics, epileptics. You talked about these very malignant causes of rash. There is a nice topic I used to teach about skin conditions, emergency skin conditions in the hospital, and some of those would be the SJS, the TEN, the AJEP, pyoderma gangrenosum, these sort of things. But yeah, seeing if this is a patient, like you said, are we seeing them in the clinic, or are they very sick and they're in the hospital and they develop this rash due to some treatment that was maybe initiated, like antibiotics and so on. So I would want to know how is the rash. With the rash, you definitely need to lay eyes on it. And also you want to see if there's systemic features. So outside job, things that you put on the skin. Inside job could be drugs, it could be inflammation, it could be autoimmune. The list is quite vast, but I think kind of we will start with this sort of generalized approach, and when we have more aliquots or more data from Aaron, we can then hone in on where exactly to focus our diagnostic workup. Anything else before we turn the mic over to Aaron?
No, I think the way you layered out all the differentials or the possible differentials and the external versus internal, yeah, I think we are moving towards the right direction. Hopefully, we crack this case. Yeah.
Okay,
All
Aaron.
right. Yeah, that was a great approach to rash. So I'll give you some more history. So this patient actually presented to the emergency department. So this wasn't like an outpatient clinic or anything. So she said a few hours prior to coming in, upon waking up, she noted that she developed pruritic maculopapular rashes over her bilateral upper extremities. And she said this was associated with generalized abdominal discomfort and generalized malaise. And yeah, when she noticed the rash when she woke up, she was just very concerned and presented to the ED for further evaluation.
So at this juncture, we have the area within which care is going to be delivered. So this was severe enough that the patient presented to the emergency room rather than the clinic. And we do have this association. Is it an isolated rash, or is it a rash in addition to other features? And what we have here is generalized abdominal discomfort and malaise. Now, it's not too uncommon maybe to have a rash, which if you think about a rash, the background of it could be inflammation. It is a reaction to something. So something happens at the skin and inflammation occurs with all the cells just running to the area of the skin and causing or dumping all their granular material, cytotoxic material, and causing sometimes destruction, edema, inflammation, and so on. And what instigated that, we don't know, but this plus abdominal discomfort plus malaise. Malaise is kind of non-specific. When you have inflammation, you do feel worn out, tired, fatigued. Your appetite does diminish. So that's not too uncommon. But this abdominal discomfort is something that is sort of cycling in my mind. What exactly is going on there? What do you have in the abdomen that could initiate or manifest in the skin? So you have your liver, you have pancreas, you have stomach, you have spleen. So maybe something involving those organs could manifest with a rash. A maculopapular rash, pretty much it's like flat rays, so it's a mixture of both, and many things could cause that. And at this point, it doesn't sound like this is very dangerous. What would mean dangerous? I would on exam look at the mucosal surfaces. So you're talking about oral, talking about urethra, rectum, all those areas, vagina, just checking the mucosal layers to see if there's involvement. If there isn't, likely not too malignant in this case. Also, if there's any pustular formation, any bullae formation, that also would be a red flag as well. What are we talking about when we think about pustules or bullae, that's where the skin, the superior epidermis dehisces. So the proteins that bind to superficial layers, those anchors are worn away. It could be worn away due to autoimmune phenomena, could be due to just inflammation, and then just material coalesces into those bullae as it rises off the skin. So when you have a large amount of that, that eventually will actually open up, and this serous material, purulent material may be expressed underneath. The dermis is exposed, and that dermis is potentially exposed to or is predisposed to infections. So it's sort of a time frame where it can be very dangerous as well. And sometimes the damage is so severe that it could be akin to a burn, and these patients may need specialized care. So we'll have to see the time course. We'll have to see how it evolves. If it is just a maculopapular rash, that may be just that manifestation, may not progress beyond that to something that could be very hazardous and put the patient in jeopardy. Labs will be interesting because, one other skin disorder that can be dangerous is drug-induced hypersensitivity syndrome, or what's called DRESS syndrome. So in that, you can get abdominal discomfort, you get liver enzyme elevation, you get all the systemic features, and plus or minus eosinophilia, which you may see 50% of the time. So still, we have a maelstrom of possible thoughts here, but I still really can't tell you what exactly is going on. But this is a very interesting. Also, age. How do you incorporate age into this, Anmol? Like a young person coming with this, and this age is very interesting, where a lot of different autoimmune things can manifest, right?
Yes, wonderful thoughts, Dr. Ravi. And I think with the clinical problem solvers, we have always said that the young age means something wrong with the genes, probably, or something wrong with how the patient's behavior or some behavior is, although that's a typical word. But I think it would be very important to know if the patient had any recent drug history, if there was any illicit drug use or any medicinal drug use recently. So I think that would be important, or any recent if she consumed any recent outside food, which she usually does not, or any recent change in her activities, that would be important. Any recent travel history would be important, since this is the hyperacute presentation. I was wondering before if it was localized versus diffuse. So since it is bilateral and associated with abdominal discomfort, it points towards a systemic cause to the rash and not just a primary dermatologic problem. So I think that is something in my mind. And another thing, I also thought that important to ask if the patient has any history of this similar episode in the past, because I don't know if I can label this as urticaria, because I did not hear the description of rash as a wheal. So it's a maculopapular rash. But if we assume it to be urticaria, so there are things that can cause recurrent urticaria. So if it is the first presentation, then I think we should look out for some triggers. If there was any trigger in the patient's history, I think that would be the most important thing for me right now. And again, I would definitely take a look upon the hemodynamics, since it's a systemic cause. So I do expect that there could be some issues with the hemodynamics, fall in blood pressure or a rise in temperature. That are some of the things that could be expected as of now. So I think that would be some of the pertinent questions I will be having. What do you think?
Yeah, absolutely wonderful. Yeah, you're definitely expanding the landscape in the approach to a rash here. So let's see in the next aliquot. I agree. Any drugs, medications, changing medications, definitely will need to know that. Back to you, Aaron.
All right, wonderful thoughts. So, okay, for some more history, because she only gave us that whole rash and abdominal pain thing, they're like, but did you have any other symptoms? And she's like, actually, 6 days before her presentation, she did have intermittent febrile episodes with a Tmax of 38 Celsius. And this was associated with generalized malaise, a diffuse headache, and a cough, which was productive of whitish phlegm. And she was taking Tylenol every 6 hours, and she intermittently had recurrence of fevers, and she basically was just febrile for like 3 days, and then after that she had no more fevers. And she had, at that time during her initial episodes of fever. She didn't have any nausea, vomiting, diarrhea, abdominal pain, urinary symptoms, joint pains. She didn't even have her rash or any other symptom at that time. And then 4 days prior to her presentation, she said she did have some episodes of non-bloody, non-bilious watery emesis, and this was still associated with a recurrent fever. But she only had vomiting on those days, that 4 days ago. And then 2 days ago, she said that was when she had her last fever. And that was at the same time her abdominal pain began to like become like a constant discomfort. But other than that, she had no other nausea, diarrhea, or recurrence of vomiting. So to clarify, her last febrile episode was 2 days ago, and that was when the abdominal pain started. And for her review of systems, she has no dyspnea, no chills, night sweats, or weight loss. She has no new foods or detergents or anything of that sort, no new medications. She's not on any medications, even besides the Tylenol that she was taking for her fever. She has had no recent change in activity, no recent travel, no prior similar episodes in the past. Um, yeah, for her past medical history, it's otherwise unremarkable. Her family history is only remarkable for question mark lupus. She said, I think someone in my family has lupus. I'm not sure. And then her parents are hypertensive. That's about it. For her social history, she's a non-smoker, no alcohol or drug use, and she's a student. Um, but yeah, I'll stop there.
Wonderful presentation, Aaron. And I think it makes the case even more interesting now since we do not see any apparent trigger. I think whenever I see the patient is presenting with a complaint of vomiting, my reflex question is if the patient also had loose stools. So it just changes the problem representation from acute gastritis to acute gastroenteritis. So I think that is one of the questions I do have. And when we have a patient coming with a rash, I think it's important to see if the rash is blanching versus non-blanching. And so if I see the history, initially the patient presented with fever, and then only the next symptoms they started. She had fever, and then only she had vomiting, and after the fever subsided, she is actually having a rash. So, yeah, I think it would be important to know if the patient had gotten all her vaccinations in childhood. I think that is an important question here. And with Tylenol, I'm not sure how much the accepted dose is, but 4 times a day, I would definitely want to know what the LFTs are. And this autoimmune thing does not really change my picture much, because more of it, I would say some of the people who are diagnosed with lupus are not actually lupus. So I would not rely much on this diagnosis. I would just focus on the current presentation, would want to stabilize the patient. And but the key question is if you want me to answer what management I would do next, I think while I'm diagnosing the case. So I think the patient, I can start her on IV fluids. First of all, that is something we can do. And if the patient had fever, so I'm just thinking if we can start some broad spectrum antibiotics. But what the source of that fever is something we need to question. Why did she have fever at the first place? Is it really infectious or was it inflammatory? So that is some of the questions I'm still struggling with. What do you think, Dr. Ravi?
Sorry. Was trying to click the mute button and a little delayed there. Yeah, it's very interesting. Now we have this fever, right? So if you take fever and then rash, put it together, infection is really at the top. Like you said, I'm going to start antibiotics, and we're highly suspicious and of an infection. Then you have to start brainstorming what kind of infections do we usually see, especially at this age, you wonder, right? You know, a lot of these questions, I deal a lot in the world of test questions, test prep, shelf, step one, step two, ABI and board exams. So a lot of these vignettes tend to have the most common infections that manifest at this age. So HIV, if we think about two buckets, then viral, bacterial, those are probably the most common ones. So at the top of the viral uh, infections that could manifest in a rash like this. I've seen HIV have a very non-specific maculopapular rash, but then you're going to have a lot of systemic features. You're going to have abnormal labs, CBC, cytopenias, and things like that. Other things to think about, the typical step question, parvovirus. If there's anemia, if there's bone marrow involvement, that could cause a viral exanthem as well. And two of the viruses I've seen where there can be abdominal pain and the liver can be involved. One is EBV. EBV at this age can happen. CMV is the other one where you will see transaminitis. We shouldn't use the term, but liver enzyme elevation. You may have malaise, you may have weakness, arthralgias, and so on. And hepatitis could be another one where you could get rash in this manner. If we turn our attention to bacterial causes, the one that I'm really worried about, especially with fever, is a do not miss condition, which is staphylococcal or group A streptococcal toxic shock syndrome. So with that, patient can become very, very sick. So they can enter the emergency room, they'll have fever, they'll have rash, and then suddenly they will just decompensate very rapidly. So you want to see what the vital signs are. You want to see, yes, Sam mentions TSS. You want to see the white count. The white count usually will be very mega, right? Really high. Left shift, bandemia, lactate. I mean, this is one of the worst kind of syndromes that you do not want to see in these patients can end up in ICU. So you're absolutely correct. Broad spectrum antibiotics will need to be initiated if you do see this condition. The other one, it could be meningiococcemia. You could have a manifestation with that at this age. You know what's interesting though? We kind of thought about young age, what else can manifest epidemiologically at this age. Let's kind of turn our attention to autoimmune phenomena, and lupus definitely comes into that, right? We're going to look for the rash. You may not always have the rash on the face, but the labs will be very interesting. The labs, at least cytopenias, complement, glomerulonephritis. You want to look for an ANA. I definitely would turn my attention to that if this is not bacterial, if this is not viral, if this is not induced by a drug. And then the next one that could occur epidemiologically at this age would be adult onset Still's disease. So in this case, ferritin could potentially be helpful as well. That's one of the causes of hyperferritinemia. So the other thing is usually you have this evanescent rash and the fever and the fever pan that you get with this. But those are a few things that come to mind. Although the potential list is quite broad at this time. We did talk about the other possible causes, stress, but those are instigated by a drug, right? So you have in the landscape of drug-induced reactions or skin disorders, you'll have the usual benign morbilliform rash, which is a diffuse maculopapular, and it's usually 4 days in from a anti-epileptic or Bactrim or maybe a augmentin amoxicillin. Dress usually is weeks out. It's like 2 to 4 weeks out. SGS-10 usually like that. AGEP, which is more pustular, not maculopapular, also in that weeks, kind of days to weeks. So it's kind of not fitting that or that mold. But I'm very interested in labs to first exam, look at the vital signs, fever, pattern of fever, rash, mucosal involvement, and then labs to look for a signature that might point towards maybe like liver enzyme elevation, maybe it is viral. And then you have to kind of hone in what kind of viruses and then do the serologies in that case. Any other thoughts on Anmol? I kind of covered a lot. I don't know if it's I I really can't tell you if it's one of these, but we can do testing. Definitely, we need HIV, CMV, PCR, also EBV, and then the CBC look for white count and so on, and blood cultures. Yeah, if it is staph or strep.
Wonderful thoughts, Dr. Ravi, and so many things strike my mind after that. And I think it would be also important to know if anybody else close to this patient is also suffering from a fever or any other symptoms. I think that history would be important too, and the possibility of this patient having toxic shock syndrome is very high if we actually are thinking about the differentials or a possibility of EBV, HIV. They are also important. So I think, as you said, labs will also clarify a lot. Yeah, all of these things, as for now, are definitely possible.
All right. So great thoughts. So I'm going to give you guys the physical exam next. So she's afebrile to 36.7 Celsius. The heart rate is 63. BP is 120 over 80. Respiratory 20, and she is satting 99% on room air. For her general exam, she's awake, alert, not in distress. Her HENT exam is just notable for slightly dry lips and oral mucosa. There's no like any mucocutaneous lesions or anything like that. Her abdomen was soft, non-tender. There was no organomegaly anywhere. And then for her uh, skin exam, she still had her maculopapular rashes over the bilateral upper extremities, and they were blanchable. There were no pustules, bullae, or anything else on the arms, and there were no rashes anywhere else. It was just localized to her bilateral upper extremities. And then, yeah, she had full pulses and no edema. And I'm actually going to share an image. This isn't actually the patient, but it's just like a representative image, just so you guys have an idea. Um, can you guys see the screen or the image? If you
Yep.
want to take a, uh, but yeah, that's the physical exam. And what do you guys think?
Anmol, before I say anything, I'll let you attempt to decipher this.
Yes, I think thanks for sharing the image, Aaron. This is something diffuse. This looks like diffuse redness over the upper extremity, something like erythroderma, or I'm not sure if that is the correct term. Um, but yeah, I don't think if I see any raised lesions because it is all just diffuse. The arm is diffusely involved. So if I would not even have the history, and I would actually could even think of if I did not have the history already, that this is bilateral, systemic, and all. I would even think that some bee stung the patient, or is it some development of some compartment syndrome, something like that. But this is a very different case. It's just diffuse redness all over the upper extremity. That is how I would describe this rash, and it is not looking good. I would say. I think the patient is pretty sick.
Yeah, I agree there as well. There are a couple of things that came to mind, terminology wise. You know, we're not dermatologists, but there are a bunch of terms that we learn. One is scalded skin. Uh, One, Hans mentioned sunburn. We talked about this evanescent rash with AOSD. Erythroderma definitely is a cause. I want to go back to this blanchable rash. So blanchable rash means that there's vascular involvement, and when you're pushing, it blanches. So does that mean that there's maybe like a vasculitis, leukocytoplastic vasculitis, for to say LCV involvement here? When we talk about scalded skin, you do tend to get disruption of the layer. This is very homogeneous and uniform, and it's very, very red. So it is almost like a erythroderma if you think about it. So scalded skin will have disruptions of the dermal epidermis layer, and then erythroderma usually is generalized redness of a predominant amount of the body. I think like 90% of the body, but it won't be as destructive as like SJS or 10. But you know, this is still early in evolution. We don't know how this skin disorder will progress over the next day, 2 days, it could change. As the inflammation spreads, it can distort surface architecture, and this inflammation can start dehiscing the layers off the underlying like basement membrane and so on, causing surface disruption, bullae, and so on. So then we could have something like SJS10 and so on. But then we're also looking for mucosal involvement. So is this erythroderma? I don't know. Usually that also is associated with drugs, or you can have certain conditions like psoriasis, but here we don't have any plaque formation here. So that kind of comes to mind. So this looks bad. The fever is concerning, although the patient wasn't febrile. But then you get this intermittent fever. If, say, everyone says now your patient has a fever, now it's very interesting. Do we have this pattern emerging that could maybe steer us towards something like adult onset Still's disease? So the causes are still very vast and many. The labs, I think, will be very helpful in this case.
All right. Yeah, so wonderful thoughts. So yeah, so the next aliquot will be the basic labs. So I'll start with the CBC. So the WBC count was actually 2,900. The hemoglobin was 12 with a hematocrit of 34. And then the diff was neutrophils 30%, lymphocytes 56%, and eosinophils 1%, and monocytes 12%. The platelets were 32K with an MCV of 83. And then for the chemistries, sodium was normal at 136, potassium 4.2, chloride 97, the creatinine was 0.6, the BUN was 12. Um, we also got an AST of 325, which is 9.6 times the upper limit, and then an ALT of 209, which was 4 times the upper limit. And then we also had a UA that was unremarkable. And I'll stop there.
Anmol, I don't know if it's me or you. Do you remember?
I
No.
can go first
Go
anytime, but
ahead. Yeah.
Yeah, I think this is very interesting. I was actually in lookout for the WBC because it actually tells you a lot if it's bacterial versus viral when you're thinking about it. But you have leukopenia here, so I'm very concerned of this patient having some sort of viral infection. But I would definitely get an HIV test here. But when you look at the other cell lines, the patient is also having thrombocytopenia. So this is a picture of bicytopenia here, which the patient is having. So we need uh, we need to actually understand why this patient is having both leukopenia and thrombocytopenia. I think it's important to send at least the viral serologies in this patient, like EBV, CMV, and the HIV. If I talk about the LFTs, I actually saw a patient who had deranged LFTs in the US only, which turned out to be EBV towards the end. So I would want to look out for that test, and I think the serologies, they can even be falsely negative as well in EBV. So you just need to get the PCR test to actually better understand that. So I believe right now I am very concerned that it is some viral picture there, and in the last aliquot we were talking about the rash, which was blanching versus non-blanching. So I think the blanching thing actually makes us more concerned that it is less likely a vascular issue, because the blood is inside the blood vessel and we are able to displace it off. Non-blanching is when the blood, we are not able to displace it, it's beneath the skin. So I think it is a systemic issue, definitely an infection going on in the body. I would want to send viral serologies as of now. Yeah, and as Dr. Ravi mentioned about the ferritin, it would be important too. if you're actually concerned about the picture of adult onset Still's disease, or with the bicytopenia, even a possibility of HLH. So I think ferritin would be important. That's what I'm thinking. What do you think, Dr. Ravi?
Oh, I just love that you sort of segued into the workup. So now I find dermatology one of the most difficult areas for a lot of the medical residents to master in because we usually don't see a lot, but a lot tends to go to outpatient. The ones that we do see that are sick may go to ICU, but on usual medical floors, we may not see that many. But when you see one, then it's sort of then recalibrating your mind, like how to approach this. But I think, yeah, if you don't have a particular condition in mind which fits the picture. So if you have toxic shock syndrome with maybe there was prolonged tampon use, you have all these key features which point towards that, you won't know. So what you start doing is ordering and ruling out the more common or the base rate of the such a condition like this. So doing all the cultures, doing all the viral panel, and seeing whatever is negative, you then weed out, and then you focus on the next set of labs that could give you the diagnosis in this case. And I think we have time, maybe a few minutes. If should we do breakout rooms? We'll pause here. I think this is a great case to maybe like stop and let other people weigh in for a few minutes on what would they do next, and does anybody have a potential diagnosis? All right, we're welcome back everybody to the main page. I hope you were able to share some ideas. Anybody want to unmute? Maybe just share if there was any interesting discussion in your room. Feel free to just unmute and discuss. Well, Sam, you brought up something interesting in our room. You could just kick it off with your thoughts.
Sure. I was, of course, thinking about tick-borne illnesses, as many in the chat were, just because of my location and how often I see them. And I do still think one of these many different viruses that can do this is probably at the top of my list. But I was telling Dr. Ravi that I have seen a fairly similar case. It just was a 59-year-old man instead of a young woman, where it was an acute leukemia causing, I mean, these bicytopenias, the transaminitis, you can get infiltration into the GI tract, and then these kind of difficult to define rashes. I have seen quite a similar case before. But with the demographics being so different, I'm not 100% confident in that, but I'm very curious to see what happens.
Absolutely, yeah, that's wonderful. We didn't really explore that domain, and it definitely has relevance. I mean, if you think about the buckets, that's one bucket also to add there. So there's so many potential causes we've kind of explored here. People also putting in the chat like tick-borne is great, right? Great thought. So Rocky Mountain spotted fever, it can be a condition that can manifest with this. Is this patient in the US or outside the US?
She's actually outside the US in the Philippines.
Oh, okay. So I'm not familiar with if any of these conditions, tick-borne illness, is how prevalent they are. If you told us she was a hiker, it kind of would correlate with that thought as well. The other thing to think about in your neck of the woods could be typhoid fever, although the rash isn't the typical rose-colored spots, but you have the abdominal pain and the association. You can have other bowel irregularities and so on. That could be something to think about as well. But at this point, yeah, I'm not sure. Just looking at the labs there, the liver enzymes are elevated. So just kind of rolling back to original thought, CMV, BV, you can get this pan-dress syndrome. This could be non-specific. And there's no other disturbance of alkaline phosphatase, no disturbance of bilirubin. So the liver is involved, and viruses tend to have this association as well. You can also have this in AOSD as well. So there is hepatosplenomegaly, and you can get this liver enzyme elevation too. So I'm not quite sure. The white cell count being low, that could be a harbinger of of sepsis. If you think about a fever, low white count usually is worse. These patients tend to do a lot worse. I would like to get differential in this case. And oh, here at the bottom, you have your differentials. The neutrophils are higher, lymphocytes are higher, one eosinophil. So just with the lymphocytes being elevated, maybe this is an indicator of viral illness. But I would get the whole viral panel. And any other thoughts on mold before we go to the next set of data?
Great thoughts, Dr. Ravi, and I love the thought of leukemia, which Sam gave. So I think the with all the patients, every manifestation can present differently. And if this patient was in India, fever with thrombocytopenia, you just cannot miss dengue testing. But it just depends on region to region. So even dengue can cause the deranged LFTs. So this is one thing. I'm quite sure about that. This is, if it is an infection, it is a viral infection. And I actually, as I said, I saw a case in the US, which was ultimately, it turned out to be EBV, which was causing the fever in the patient. And the fever was not subsiding with anything. And it just, and the patient even had splenomegaly, and I think he also had a splenic infarct. So EBV can present like that. CMV can do that. We can even send the hepatitis viral serologies if all of that turns out to be negative. And I think and these would be my thoughts. And I if dengue is common, that common in Philippines too, so sending a dengue test or the arboviral test would also can also help. And about the lymphocytosis, it's yes, it can happen in viral infections, but it can also happen in malignancy too. So definitely we can get a peripheral blood smear to see if there are any blasts, but that would be just another test. And HIV test would be important. And if we are not getting to a conclusion, an ultrasound abdomen can also help. But that is what I'm thinking right now. And obviously a ferritin test too. Yeah. Over to you, Aaron. Great case.
Yeah, one thing to add is if I wonder if Aaron has the tourniquet test for us as well. Over to you, Aaron.
Yeah, we actually did not do the tourniquet test, but yeah, wonderful thoughts on everything you guys have said so far. Like, I purposely didn't include the patient's location earlier because I feel like that would have just narrowed the differential way quicker, and I feel like it would be a much more rich discussion just to not know where this patient is coming from. But yeah, those were all great thoughts. And yeah, I'm gonna give you one more aliquot, which is just the imaging, which was just, she just got a chest X-ray because she did have a cough, so we checked that and it was clear. We got an abdominal ultrasound as well because she was just, to check the liver, but it was otherwise unremarkable. There was just minimal trace-free fluid. What do you guys think about that, or does that change anything for you guys?
Yeah, I guess the ultrasound we're looking at, so the liver, it's not enlarged. We don't have hepatomegaly, it's not mentioned here, splenomegaly. So, but I would push through with the testing, the hypothesis, I think at the center. Now you mentioned Philippines, I think Anmol absolutely hit the nail on the head with dengue being possibly likely in this DDX. But again, we still have to do our due diligence and go through the base rate of such a presentation, EBV, get all the serologies to rule out those conditions.
Yeah, I totally agree with Dr. Ravi. The testing for that would be important. And then I think in such cases, we do think whether giving antibiotics was helpful in the first place or not. I think this is some of the cases we do think, because the patient has presented to us in the emergency. Patient is having rash and he's having fever. So what are you going to put in the treatment chart? There would be one of the other antibiotics. And when you see the TLC, total leukocyte count, you think it's likely a viral infection. So I think these are some of the management things we do come across in the hospitals. So yeah, I think maybe we can probably stop, or the reconsider giving antibiotics to such patients. I think IV fluids would be great in this case, and let's I'm all ears to see what kind of viral infection, if it is, turns out to be.
Yeah, great thoughts. So the serologies came back, and unfortunately, we didn't get all those serologies. We only got a dengue serologies. The NS1 antigen was negative, and this patient was positive for dengue IgM and IgG. So, yeah, so the final diagnosis for this patient was just dengue with warning signs. And I guess the learning point, I mean, for us who are familiar with dengue, it's we're very alert for the warning signs that these patients may have, such as like abdominal pain and bleeding. So for this patient, her warning sign would be abdominal pain, which could suggest more plasma leak. So that's like one of the main concerns. And overall, yeah, this patient's presentation is just very consistent with like classic dengue that we often see in the Philippines. So this is like one of the bread and butter cases, similar to probably how Sam's cases have like tick panels, like for every patient, pretty much everyone in the Philippines, like coming with a fever and like abdominal pain and rash, just get like a reflex dengue just in case, because like it just could be that. So most of the time it turns out to be just dengue, well, just dengue. But for her, it was just the way she presented herself. She was more concerned about her rash and not really this like preceding fever. So that whole febrile phase of her initial illness, like she didn't like voluntarily give that. Just she was just more concerned, like, oh my God, I have a rash and my stomach hurts. But if you look at the big picture, it is very consistent with dengue with her initial fever that was like on and off. But like classically in like textbooks, people would have like retroorbital pain and like headaches and like bleeding from the gums and the nosebleeds, but this patient didn't have that. So, yeah, that's pretty much what happened with her. And she was admitted for just fluid hydration and supportive care because that's basically all you really do for dengue and hope that it doesn't progress to any more like severe plasma leak and shock. So it's just fluids, and antipyretics as needed. And she was just monitored with serial CBCs. Her blood counts improved and yeah, her LFTs improved as well with just uh, time and fluids. But yeah, that's that's this patient.
Wow, amazing case, everyone. It's my first dengue case. We've had quite a few dengue cases that have been presented. I've never seen it, so it's not familiar. So it's not something that's going to come like be the top of my mind. But Anmol said she's seen many cases and was like right on top of this and got the diagnosis early. But very informative. And I just love you kind of withheld that. And we explored the whole background of rashes. And I think this was really, really, really educational, really helped me try to improve my thinking and approach to rash and also teaching rash. So excellent, excellent job. Thank you for putting this case together. Anmol, any reflections?
Yes, I think textbooks always form a spectrum of how a disease presents based on so many presentations they have seen. So they range it from normal, not just the normal dengue, or to dengue shock syndrome, to things like that, or dengue with a rash. So I have actually seen cases with dengue affecting the heart, causing cardiomyopathy. So people often say that that this dengue actually, so many of my friends have it, but why am I suffering so much? So I think that one same similar disease affects all the people in different ways. So it was interesting to see how this patient presented with a rash, which turned out to be dengue, and it's great that the patient got diagnosed correctly and received correct treatment. Yeah, but and if you would have actually mentioned Philippines before, I think probably the dengue would have been up on the list, because I just know that it is not that common in US, but I don't know about the other places. So, but in India, if you have fever with thrombocytopenia and dengue, straight away, you need to test that. You just cannot miss it. But great case. Thank you, Aaron, for bringing it. And it was an honor discussing it with Dr. Ravi. Thank you, CP Solvers, for giving me such opportunities. Always. Thank you.
Awesome. Yeah, great discussion. Just shows how much you've grown since joining CPS, Clinical Problem Solvers. And we have Lyra who will do the teaching points. Take it away, Lyra.
Yeah, thank you all so much. This was absolutely incredible session. And yeah, the case started off with the rash. And interestingly, the initial approach to the rash is very similar to the approach to any neural system problem. So it's localization time scores. But another questions that we can ask when we again see the rash. The picture here is worth 1,000 words. First is how deep the rash is, and second is how wide the rash is. And this can help us understand, is this more of an outside or inside job? Another things to ask a patient when we see a patient with a rash would be exposures. Also the setting that we see a patient, is this a clinic patient or a patient that we see in ED? And also vaccination history can also be very helpful sometimes. And right away, by assessing vital signs and also mucosal surfaces, we can check for no miscauses, which in cases of the rash would be primarily T and SGS syndromes. Then, when we see any associated symptoms, we start to think more about systemic causes and so-called Rash plus syndromes. And we start to think more about them, especially when we see a bilateral presentation or diffuse presentation of the rash, and also some other associated symptoms, like in this patient, it was abdominal pain and fever. So for inflammatory rash, we think of R, again, differential through I mnemonic with capital I, representing the infection, which we think before we're thinking about anything else like autoimmune diseases like SLE, ALSD, or celiac diseases. And in terms of the infections, we can also divide them into our common buckets, namely viral infections and bacterial infections. And differentiate between them can help. To differentiate between them, CBC can be really helpful, as it was in this case when we saw leukopenia, specifically, namely neutropenia and thrombocytopenia, which indicates a high probability of viral infection in this patient as compared to bacterial infection. And in right context, when we see such picture, we need to prioritize, for example, tick-borne diseases and arboviruses like dengue, which was the case, the final diagnosis in this case. And another important point, as was emphasized by all of you, that typical presentations of common diseases are should always be prioritized rather than common presentation of atypical diseases. And another caveat to this is that the common disease is a relative value and the base rate is also a subjective value. So for example, dengue would be so crazy atypical in my setting where I practice, but it's very typical in Aaron settings, and it's just a beautiful, beautiful case. Thank you, Aaron, so much, and Dr. Ravi and Anmol for incredible discussion.
Absolutely wonderful, Lyra. Thank you very much for doing teacher points. Also, Sam, for jumping in to help with scribing. And yeah, you never know this patient. A patient may just come in from the airport, what we call fever and returning traveler, and come with this disease. So thanks to Aaron, we'll be able to identify this condition in the future. Thank you, Aaron, once again for presenting this case and bringing another wonderful case to CPS. And there'll be another session tonight, so please join at 6 p.m. Where we'll have a rheumatological VMR, 6 p.m. EST. Take care, everybody. Otherwise, have a great rest of your Tuesday. Take care. Bye.